So, we've all got just got back from Atlantic City, the National Conference on EMS, and I've been a few places. I've been at the EMS Expo, the NET Conference in Boston, Georgia for meetings, and at Medway, and then Delaware, and a bunch of first aid squads. Ran around Robert Wood twice, and welcome. So congratulations to the EMS fellows who got 7 appetites accepted at NAMSP, and we'll be lecturing there on field physician response. We're going to do our usual journal club. We are here today at Monarch's Education building. So let's get started on interesting cases.
All right, I have one. Can you hear me? We're good. So we had the last clinical shift that I worked. We had a 59-year-old gentleman who was brought in by EMS. We did medical control, which notified us that the patient was on a flight from China to Newark, and en route he got up. He started kind of feeling warm. Got up to go to the bathroom on the flight, and remembers kind of feeling faint, passed out in the bathroom, falling forward, and then kind of opening the door of the bathroom in the airplane, was able to get up, was with the assistance of the flight crew, and en route back to his seat, had another syncopal episode. There was a physician on board who kind of started or assisted him, noticed him to be had some diminished breath sounds, was tachycardic and somewhat hypoxic. So they put him on oxygen. They gave him a NEB treatment. Once they landed the flight, I think they said they had probably another 45 minutes before they landed in Newark. EMS got there. They noted the patient to be hypoxic to the 80s. They continued to put him on oxygen. They tried to take the oxygen off at some point, I think maybe in transfer. He syncopized again, and they noted that anytime that he went without oxygen, he just syncopized. So he was tachy to the 110s, 120s, and very diaphoretic, cool, and actually had some central, perioral cyanosis. So when he got to us, we pretty much figured he had, it sounded exactly like a PE. We rushed him straight to CT. We registered him and had him in the scanner in about 15 minutes. And he indeed did have bilateral pulmonary emboli. The question was, should this patient be given systemic TPA? Was he a candidate for ECOS, or should we just start him on a heparin drip? So once we got to him, his blood pressure initially was about 110s over 70s or 80s. He was tachy to about 120. Got him on oxygen. He kept saying, "I feel like I'm going to pass out. I feel like I'm going to pass out." The lowest his blood pressure ever got when we were in the department was 104 systolic, and heart rate stayed around 110. We kept him on a non-rebreather. Whenever we took the non-rebreather off, he would go down to about 80, 85%. But he had a decent blood pressure. We did the bedside echo. You saw that the right side of his heart was dilated. He had a small pericardial effusion. But that was pretty much it. So the question, we activated the PE response team. The question was, again, from CCU side was, should this patient be given systemic TPA? The CT itself, we suspected there was going to be a massive, a big saddle pulmonary embolism. And actually, he had bilateral segmental and subsegmental PEs. Lab-wise, his trope was 0.34. You could see some right heart strain. He had some LFTs. You could see a little contrast back at the liver on the CT scan. But his labs were grossly otherwise unremarkable, but he was very symptomatic.
Can you define the PE response team?
So we had the new initiative at one of the facilities I'm at. You have PE response team. So any patient that has a pulmonary embolism. I think more so with more symptomatic, not symptomatic, but more unstable presentation, you activate the PE response team, and then you alternate it between CCU or cardiology versus pulmonology. And then they kind of direct the management of the patient, whether it's going to be systemic TPA. If the patient isn't already given TPA by the ED treatment team. So if you're going to do ECOS, that is the big thing. Who's going to place the catheter? Who's going to manage the patient? And it alternates between pulmonary versus cardiology. In this particular day, it was actually cardiology on.
How often do you activate the PE response team?
For any massive, submassive PE that
Like clinical presentation as soon as they hit the door, or after the CAT scan is done?
Anytime I've actually activated, it was after they hit the door. If it's a patient that I suspect has PE and it's obvious that if this guy came in, he was hypoxic and tachycardic and not maintaining the blood pressure, I would just give the TPA myself. I don't need the team to help guide that. It's more so this patient is quasi-stable, or do they want to do ECOS? I think that's probably the biggest thing from a management standpoint. Obviously, the ED isn't deploying the ECOS catheter.
Are they able to start ECMO as well?
It's if the patient needed it, they could, and it's just having the advance. I mean, these patients. I think it's pretty much any patient who's going to need ICU level care. These are both, whether it's cardiac ICU or medical ICU.
Do they actually end up doing stuff? Because
so this patient actually ended up going to CCU. He is going in this morning for ECOS catheter.
I mean, can you do ECOS after hours?
Sure, you can. If you have the interventional person who comes in and places it.
So nobody's in the house though, right? I mean, IR is not in the house.
Well, IR is not in house, but which IR would be needed if it was ICU. Otherwise, it would be interventional cardiology.
Right, but they're not in house either.
Who's not in house, but should theoretically be more on call, responsive to a call situation. They also the STEMI person.
I mean, I would think that the utilization of ECOS is quite rare, right, for PE, whereas the potential to call the PE activation is potentially very high. Right. So we have PE in every differential. Now, if we're only being called for hemodynamically unstable, is that what you're saying?
Right.
Hemodynamically unstable people who are short of breath.
Exactly.
So you're not suspecting heart failure and all the other stuff.
Exactly, right. So the patient who comes in with a PE, who I think one can either go home on, a DOAC, you're not activating it for this patient. A patient who you think can be managed on telemetry, you're not activating for this patient. Again, I think it's probably a more ICU level care patient.
I agree. I think depending on the site specific, for us, cardiology is a lot more aggressive with ECOS than pulmonology are. They're more to say hang systemic TPA at the bedside or have it ready. But I think it's all dependent on each facility and their aggressiveness with dealing with these patients.
did they end up doing ECOS in this patient?
They did. They followed up, and the patient actually was catheterized this morning.
Like the next day? Is this morning the next day?
This morning, what?
And they didn't do it like right away because why?
I don't know. I don't know.
Did the patient get TPA in the meantime?
The patient did not get TPA. So that was, again, the biggest question. I think we all were, and I think that this is kind of the basis of the PE response team and pulling the trigger for TPA. You have this patient who comes in and no one is sure, like you're kind of in limbo as to, should I give TPA? Should I not give TPA? Should I, I think it's very clear, everyone is very clear when they're going to give it for the massive PE, the patient who's very unstable. Like no one is questioning if you're going to give it then. And I think that for my practice, that's the exact same way. Like I don't question whether I want to give systemic TPA to that patient. It's the patient who his blood pressure is 100, systolic, he's mentating, on high flow nasal cannula, he's saturating well, he's talking to me, he looks better than when he came in. So our interventions are working. He is stabilized. Should you still give systemic TPA because technically he has some right heart strain, he does have a troponin leak. He is his blood pressures are somewhat soft, or is he stable enough that he can be managed with the ECOS in a few hours? Now, this is less than 10 hours, I think, from his presentation or 12 hours from presentation to the ECOS catheter. For in this particular case, I think it's probably like other things in medicine. If it happens between 8 or 9 to 5, then it's a whole lot easier to get done than if it happens at 2 o'clock in the morning.
So if the ECOS catheters generally works, what's the indication now for like a pulmonary thromboendarterectomy? Like, is there, that used to happen, right? There are people who did it for years. Is there any indication now for it? Or I
I've
assume.
never even heard of one being done
Right.
since I've been doing.
Right. Yeah.
It's
Never
always,
heard of
it's
one.
always been ECOS catheter.
Right. You see the picture,
Yeah, and
but that's
Yeah, one of the other spots that I'm at, decisions made by the ER physician, and then you just call interventionals to get them to say, we agree. But very rarely do they ever shoot us down.
yeah.
So it's just another thing in medicine that you have to come in during daylight hours for,
Right. Yeah.
right?
They will come in at night, that at least.
They'll come
It
in,
depends where you are.
they'll come in at night for the purpose of ECOS.
Yeah.
How does an IR freaking change, right?
It has.
We'll never have enough IR people to do all the things we want 24/7.
Slowly
And I guess if you
surely.
had to prioritize, you'd probably prioritize trauma, maybe, but maybe not. Maybe like a real PE. Wait, are these guys gonna be sleeping in house?
I think eventually they will be.
Seems like there's a lot of
They're doing more and more by the day.
right.
Even if you're in a busy center, if you're not, or you have to be in a big, busy
You have
center.
to have high volume,
Right.
be able to pay someone to be there.
Starting to see some of these grabbed by the other subspecialties as well. And surgery is expanding their scope into some of that.
Right, like everybody has interventional fellowship now.
Correct.
Renal has
Interventional
interventional
neuro-
nephrology.
Interventional neurology.
Right,
You
it's
know,
interventional everything, interventional, right, everything. Everybody wants a piece of it.
Right.
Okay, so hopefully something good will happen today.
Hopefully. I think he's out.
So what do we do pre-hospital? I guess it's a PE, what are you gonna do pre-hospital, right?
Yeah.
Give oxygen, intubate if needed,
Right.
and we get nothing else, right?
Fluid, yeah, support
Yeah.
that breaks
Reload.
on it. Make sure you
Support the blood pressure.
So the argument would be like, the patient with a massive PE is probably the most challenging patient to intubate. And
Start
these are
on
the
that
patients that, these are patients that will code on you, post intubation. And just because of the fact that you completely knock out their preload, and these guys are completely, they don't have, the burden is because of the fact that they're not getting any throughput to the LA. And so now if you decrease that preload to begin with, if they're not getting enough of, you'll knock them out completely and they can arrest them.
I guess the question would be, would these be the patients that you are more likely to just do a sedation-only intubation to not take away that drive that they are doing?
Sure, the problem becomes, for these patients, not so much as that if you paralyze them and you take away their systemic resistance, because it's a mechanical, it's an obstruction, right? So, it's the preload that you get knocked out when you increase the intrathoracic pressure so much as anything else. I think, the septic patient we talked about, if we paralyze them, sometimes they can bottom out on us when we paralyze them.
Plus you're taking away ventilation.
Right.
That's the risk.
That's their compensation, right? So I know a lot of times people get worrisome, like the patient's hypoxic, they're tachypneic, they're tachycardic, they're working really hard. Like, I got to tube this patient. The problem becomes is that that's the patients that will code on you because they're compensating completely. And so we ultimately, shouldn't try to do that. We should probably give them TPA. So that patient is the one that we say, you know what, I'm not tubing you. I'm actually going to give you systemic TPA and see if I can reverse this process instead of saying, I need to take your airway. And I think pre-hospitally, this is the judgment call that we have to make as far as, do we intubate this patient or not? Or do we need to bring them to a different location where we need to probably, give them some type of intervention? I think that's, for the pre-hospital provider, the very challenging patient. And that's the patient that can become, that can decompensate.
Yes.
Question about CPAP in that setting.
Yeah, I
So-
know. I mean, that's a really good question. I, think about that too. I mean, you could. I mean, if you're going to stent someone a little bit, then I think honestly, bi-level approach would be more appropriate
Mhm.
because of the fact that you can give them a good IPAP and then you can dial it down a little bit too with the EPAP. But then pre-hospital, all we have is CPAP. I'm okay with it,
Right.
but I would use very low PEEP, right?
Right.
So
That's my big issue.
if I did do CPAP, it would be very low and high flow, and I think that would be okay.
Yeah, and there is a new pre-hospital iPad device. I think there's only one on the market.
Oh, really?
It's made by Mercury Medical. I don't think, somebody told me that, I'm sure somebody can correct me in the audience if I'm wrong, but I think Homodyne is working on one, but Mercury Medical has an approved product on the market, which is BiPAP. Right, so I guess that makes sense. I mean, it's a fixed lesion, it's PE.
Right.
Is positive pressure going to help?
No.
No, I think the
No.
reason I brought it up was because most people in respiratory distress are gonna go to that in
Right.
today's world. And so are you causing yourself a problem in that setting?
Right, I see your point, and obviously, potentially if you're high enough, you're potentially reducing preload, which certainly not what you want your
Right.
patients.
Right.
On the other hand, if you're gonna send a message out to the EMS world in general, I like the message that CPAP does very little harm, give it to the masses.
Agreed, especially in the usual 5 to 10.
Right, stop thinking too much about it,
Yeah.
throw it on if the person's short of breath and not doing well.
The medics did a great job. They actually came in, they said, hey, we have a patient with a PE. I was like, is this a transfer? Or-
It was labeled on there.
Yeah. They did a great job. And they did not put him on CPAP. She did a great job. She did a really good
Did
job.
they intubate pre-hospital or no?
They did not. You said, do they intubate pre-hospital? No, they did not intubate pre-hospital.
Did they do any, I mean, did they
They,
give
no, they,
that's because they thought they were wheezes or? did they-
no, they said that they felt very strongly that it was a PE. They did not want, they did high flow, non-rebreather. And as long as the patient was on the oxygen, wasn't straining himself, he was actually okay. Like from a vital sign standpoint, it was when they tried to transfer him from his seat or from on the plane to off the plane to in the unit to on the patient bed, like any type of exertion, he just completely, it took everything out of him to the point where he would syncopize. And so they said they just, they had him stable. They didn't want to give him any, they didn't want to give him a NEB treatment because he really had no history of asthma or COPD, wasn't a smoker, no reason to think that there was anything. And he had been on a very long flight. Like their what they had to say that this was a PE was really high. So
You have pronounced at the door, I assume?
I called for heparin and everything. The heparin unfortunately was not ready. By
Did
the
you
time
call
he
for
was there,
TPA just to be ready?
I did. I had TPA
Who
pulled up.
cares about the heparin that much?
Right.
I've been asked this question so many times over the years. Shouldn't paramedics carry heparin? And the answer is no.
Right.
I mean, you're ordering PTTs if that's what you're using,
Mhm.
like in 6 hours, right? To see if they're
Right.
therapeutic.
Right.
Unless your transport time is 5 hours, there's no benefit to even with the bolus,
Right.
which we normally always underdose anyway.
Right. Exactly. So it was funny. The physician who treated him on the flight actually called to check in on the patient and get an update and said, I was really concerned that it was a PE and they actually had a 5,000 unit bolus of heparin on flight that I almost gave him. But I wasn't sure, so I just gave him an aspirin because he was a little diaphoretic and wasn't sure if this was cardiac and related or not. So I just gave him the aspirin instead. And his other concern, which was also a concern of mine, and we addressed it, was that he syncopized twice. One, again, remember he hit the door in the bathroom, and then it was also in the aisle. So we scanned his head before, just because I was anticipating we may give the TPA.
So they had heparin on board the flight.
Yeah.
So let me just see if I can see anything radical. I think that I would never allow heparin to be on a plane in a medical bag. What do you guys think?
Agreed.
I mean, you have chest pain, you're sure that maybe you're dissecting, maybe you have a pericardial effusion.
Right.
You know, why would you put heparin on a plane? I mean, what benefit could occur? I mean, I guess you could have a 15-hour flight, but that's okay. I mean, I guess you could have unstable angina on a 15-hour flight, but if
You
it's a
also
15-hour flight, you're going to be able to divert somewhere.
Right.
Right.
You also need someone who knows how to give it and knows when to give it. And
Yeah.
that's the issue I see with that. It's just like a bunch of people put on Narcan on all their flights now because someone overdosed in the bathroom, but they didn't find the person for a couple hours until
Right.
later.
Yeah, that's
So the
okay. I
Narcan
mean, I would
was
say with Narcan, what's the downside?
I mean,
So just give it, right?
as much as there's a benefit of giving heparin to ACS or PE, there's a lot of clean kill you can do too,
Exactly.
or
With
potential.
the undifferentiated
Right.
patient who's, is this a dissection? Is
I mean,
this a
someone
PE?
keeps
Is-
sympathizing and you think this patient have an aneurysm.
Right,
rupture,
exactly. Exactly.
Now I'm gonna get this ruptured aneurysm that's, if it's a ruptured aneurysm that's surviving, it's retroperitoneal, right? So that's kind of where they bleed into somewhat can contain.
Right.
So now we give this person heparin,
Right.
Yeah.
we're seeing the symptoms,
Yeah, and despite the one bad article, syncope, P is really rarely in differential of syncope.
I think also something to consider in hospital is that the actual dosing of TPA, if we do give it for PE, because I've had multiple times where I order the 50 according to the studies, and yet I've had the pharmacist call me every single time almost and be like, "You sure it's not 100?" And I'm like, "No, I ordered 50 for a reason."
Right.
And that was the discussion. That was actually quite a bit of discussion that we had. I told the team that was responding that I said, if I'm giving TPA, I'm going to give 50 milligrams, and we'll do a 10% bolus push or 10% bolus, and the rest over the 2 hours, and not give 100. And they're like, well, it's 200, or excuse me, it's 100 over 2 hours. I'm like, no. And so, reviewing the literature again, and, they weren't fighting me over it, but it was, again, something that comes up, and I've had the exact same thing come up. as
I
well.
have no doubt some people are protocol to agree with pharmacists. I mean, you guys know about, what's it called, National Guideline Clearinghouse, right? Is that what it is? So you can go on there, just put in a Google search engine, and it'll pull up every guideline ever written by the American Society for Left-Handed, blah, 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 blah. Every guideline ever written by anybody. And the only reason we hear about guidelines from the American Heart Association, American Stroke Association, is because they're bigger companies with lots of marketing material. Lots of companies write guidelines, right? So, right. So, who would put heparin on a plane?
Whoever designed that.
Well, sometimes they'll just have heparin on the plane because maybe someone else needed it. We've been on a couple of medical flights that we do where I found a freaking vent, a full vent with full circuit, everything. It wasn't mine, but it was just there.
So who's checking these vents? Like what biomed company? I mean, I would assume somebody is, but I assume that this is that's regulated. In fact, I know it is. It's regulated. But but we're doing interfacility transports. I mean, we're just
different.
continuing their heparin that they've already been placed on for probably good reasons. But for undiagnosed chest pain or shortness of breath,
You can do harm.
yeah.
They don't have that.
uh,
I think it depends on the sophistication of your kit. I mean, if you've got the ability to do a 12 and you get a raging STEMI in the middle of the ocean, maybe. But it's got to be a pretty big. You have got to be 100% sure that's a STEMI, and the guy's got to look like a STEMI. And the only other time I'd consider giving heparin is like major cerebral dolens, which is super rare. But
right. So that sounds reasonable. Which is quite uncommon. We don't
super
think
rare.
about it, but right.
I mean, and those are both like, things you read about in the textbook. The chance of you actually seeing it on a flight over the ocean,
Right.
come on, but so, you're probably wasting a lot of heparin.
Yeah.
But if you're having a STEMI, it's because of plaque rupture. What's the heparin really going to do acutely for the plaque rupture?
Very
Right?
Very little.
Yeah.
So.
You
Agreed.
jeopardize somebody over a flight and they fall getting off the flight. Right, the usual stuff.
Banging their head on the door.
Well, on the way out.
Luggage fall.
want to do an article or?
Yeah.
Two, what's the best article that you guys do that one first?
Who's got one for the cardiac arrest?
It's really, mine is relatively short, but so I'll go. So my article is from the Western Journal of Emergency Medicine. Paramedic out of hospital cardiac arrest case volume is a predictor of the ROSC. So we know that there are lots of factors that influence the survival of the out of hospital cardiac arrest or OHCA, and then one of them is quality of resuscitative effort, which could also be influenced by the medic's exposure or the case volume to the OHCA. So this study investigated the relationship between OHCA case volume and then survival. So this study was done in North Carolina, and then this is retrospective observational study of the influence of the cardiac arrest case volume on ROSC using the North Carolina Pre-Hospital Care Reporting Database. So what the authors did was they basically looked into their database who had cardiac arrest in North Carolina between January 2012 and June 2014. So they included pretty much all of the adult patients 18 or older who suffered the bystander or EMS witnessed non-traumatic cardiac arrest. And after they identified those patient population, they searched, they again looked into the database and then searched by the primary paramedic attending to each patient in the sample to determine his or her number of the cardiac arrest cases treated in the previous 5 years. So basically the focus was not the patient, but more the paramedic, how many OHCA cases they treated in previous 5 years. So there are 6,405 patients included in this analysis. And then for the patient, the mean age was 66.5 years, and then 61.7% of them were males. 30% of them had a shockable rhythm on the initial presenting rhythm, and then the mean EMS response time was 8.3 minutes. So, and then also 44% of them had a layperson or the first responder CPR before the EMS arrival. So in total, 3,155 patients, which is 49.3%, which is almost about half of the population, experienced ROSC. And then the lead paramedic attending the patient in the database had participated in the average. So lead paramedic had average experience of the exposure to OHCA in like 23.6 cases in previous 5 years. So university analysis, what they found was that the greater population of the patient who had the ROSC received layperson or first responder CPR, and then they presented with a shockable rhythm, which is not surprising at all. And then also the patient with ROSC also had a shorter EMS response time. And they were treated by the paramedics with greater or more 5-year cumulative OHCA experience. So they used the logistic models to eliminate the bias, confounding bias, and then they basically used the variables such as paramedic OHCA experience, 15 or more in the previous 5 years, patient age, gender, non-complication rates, and shockable rhythm as an initial presenting rhythm, layperson or the first responder CPR, and then EMS response time. And what they found was ROSC was more likely when the patient was treated by the lead paramedic who had attended 15 or more cardiac arrests in the previous 5 years. And then they decided to do this 15 or they decided to divide 15 or less or 15 or more because this level, they believe this level of the case volume was so that ROSC by the OHCA case volume appeared to be plateau around 15. So they decided to do the 15 make 15 as a cutoff for this study. So in conclusion, what they found was that they found that the patient treated by the paramedics with 15 or more OHCA exposure within last 5 years has a greater chance of getting ROSC. And then there are several articles which look into this similar kind of research, and then they had a sort of similar result. So in conclusion, so in order to achieve the greater rate of the loss, they recommend maybe implementing the strategies to increase the paramedic cardiac arrest case, more exposure to the cardiac arrest case, or expose paramedics to like a high fidelity simulation to simulate the cardiac arrest may help improve improving the rate of the loss. Well, I think this study makes complete sense, and then the more experience you have in the OHCA, you get used to it, and you kind of know what to do. And then, but I don't know if the number they are saying like 15 or more in previous 5 years. I feel like this maybe is just a little bit made up. I guess. What do you think?
That's only 3 a year.
Right. And I
These
think
numbers are incredibly low.
right, and I think
And maybe it's just because, they're including new providers that don't have 5 years, but, it's still their total for the past 5 years could be all in one.
right.
So, sure. But, yeah, I mean, it just makes sense. The more you do it, the better you get at it. There's even the mention of another article in here, just with ETI exposure and survivability. Not necessarily all the rest of it, but they even, it was one of the first articles I've seen where they actually write very high intubators, so to speak, which is greater than 50 in the previous 6 years. I mean, that's like, for paramedics in New Jersey, that's like a year. But anyway, those people had much greater survivability, which you see these things. It's hard to put it all out there, quantify it, but of course, if you haven't been exposed to it, it's really tough. And as good as any sim lab happens to be, there's no sim lab that can truly give you what doing it in the field gives you.
Right, but perhaps the sim lab can do justice to the hospital cardiac arrest,
Absolutely.
but the pre-hospital one.
That's a whole other
Yeah.
can of worms.
Yeah, there's many variables, and also there's a lot of adrenaline that goes through your system. It's very different. I actually find doing like a real patient easier than the simulation, because the simulators are all stiff, but some of our patients are too. Sometimes they're on the ground, things like that, and it kind of makes sense. The more you do it, the better you are.
I think a constant exposure to the actual cases is that will do more, do better.
But that's why we're also proponents of high fidelity simulation on cases where it's high stress, low occurrence. So things that you don't normally do, like that's the whole reason behind competencies. So you have people come in once a year. It's like, hey, when was the last time you did this? All right, let's do it right now. Things like that. Things that that your people aren't doing all the time. Let's refresh that. If you know they're doing 50 intubations a year, you don't need to go over intubation. You need to go over the pediatric intubation that they haven't done in a year. You need to go over the cricothyrotomy that they haven't done. You need to go, those are the things. Or even patient presentations where, we might not see, we see CHF all the time, but maybe we don't see, the toxidromes. So having someone present with a toxidrome as part of your competency.
Okay, sounds good. One more?
Sure, mine is quick. It's the article on futility of out-of-hospital cardiac arrest that can be summarized with 3 simple criteria. It was essentially, it seems like more like an op-ed, like a letter to the editor more than anything. The original article was a retrospective analysis of the cardiac arrest registry to enhance survival database, which included 1,750 patients, 223 of them which met the criteria that they had a non-shockable rhythm, they had unwitnessed arrest, and they were found to be over the age of 80. Of these, it they predicted that these 3 simple criteria, which were mentioned, is that these criteria predict the futility of resuscitation and whether we should even start the resuscitation or not. The authors of this, they applied kind of the same study, but they used the French National Cardiac Arrest Registry, where they were able to get 85,000 out-of-hospital cardiac arrests in March of 2018. From that, their population that met the criteria actually came out to about 2,481. And one of the things that they excluded patients that the care was not undertaken by their mobile medical team, which consists of an ambulance driver or nurse and a senior emergency physician. And those were the 3 minimum that were on the team. So they got the 2,400 subjects. Among them, they had ROSC in 13.6%. Survivors at the end of 24 hours were 7.9%, and survivors at the end of the 30 days was 0.8%. The characteristics of the survivors and non-survivors were about the same, and the electrical asystole was more common in the non-survivable group at day 30. And as well, they were noted to have a lower maximal value of the end tidal during the resuscitation, and the median time of death for them was about 1 day. So they brought up how the decision to not partake in a resuscitation, that they should just call it time of death, it should be more thoughtful than just the 3 criteria alone. To consider a lot more comorbidities and kind of situation. They did mention how there is trauma related to families seeing their loved ones being resuscitated. However, there's a trauma on the other side of it, of family members saying, "You're not doing anything. Why is no one doing anything?" So that's really the biggest thing that came out of this, is that using more of a judgment than just the 3 simple criteria to decide that this is a futile resuscitation and that's it. It was very short.
Any thoughts? We actually have 10 more minutes. We do one more.
Okay.
What else do we have?
We have can we do the bolus dose epi, the push dose epi?
Sure, whichever one you guys want to do.
So the
It pains me to
so this was in pre-hospital emergency care. Bolus dose epi improves blood pressure, but is associated with increased mortality and critical care transport. So the objectives, they tested if bolus dose epi administration to profoundly hypotensive patients during critical care transport is associated with survival 24 hours after hospital arrival. They had secondary aims included evaluating the association of push dose epi with survival at hospital discharge and at 30 days. And they examined short-term measures of efficacy, such as blood pressure response to the push dose epi as well. This was a retrospective case cohort study, including patients transported through or by a single large critical care transport network based in Pittsburgh, and included adult patients greater than or equal to 14 years of age with profound hypotension defined as a systolic blood pressure less than 70. In regards to their education, they introduced it during flight crew education sessions in May 2015 and required the push dose epi by protocol in July 2015. And crews were directed to administer 100 mics of epinephrine through a running saline line with preserved pulses and systolic blood pressure less than 70. That was a criteria. The crew had the option to repeat that dose up to 4 times until blood pressure exceeded 70. And then the protocol directed them to simultaneously initiate resuscitation with a volume bolus, followed by a levo drip, irrespective of the type of shock they suspected the patient to have. And for patients who remain hypotensive despite those measures, then they got in touch with medical control. So the first table 1 in regards to characteristics of the patient cohorts, pre-index event, with the pre-index event being the systolic blood pressure less than 70. You see that they had in the no push dose cohort, there were 2,700 patients, and in the push dose cohort, there were 571. And a couple of interesting things regarding the characteristics and their types of shock. You see trauma was one of the major ones with 1,006 patients out of their total of 3,300 patients. So which makes up about 30% of their patients being traumatic types of shock. Other aspects of it, and within the push dose cohort, statistically significant were the blood pressures of systolic blood pressures, diastolic pressures, as well as airway status. In regards to how they assess the patient or how they gather patients, it was a total of 4,925 hypotensive events. 550 were excluded because of age criteria, which left them with 4,374. They divided that further into cases before the implementation being 2,700 and cases after being 1,600. And eligible cases that received the push dose, that ended up with 571 patients, and patients that did not receive the push dose pre-protocol was 2,731. In their table 2, characteristics and patient outcomes following the index event, we see that in regards to statistically significant, the mean systolic blood pressure 10 minutes after the index event, we see in the no push dose cohort, there was 88.9 and then 98.9, as well as in the systolic blood pressure less than 70 anytime after the index event was also statistically significant. CPR after the index event, as well as vasopressors after the index event. And then in regards to hospital outcomes, the 24-hour survival, the survival to discharge, the 30-day survival, and the overall hospital length of stay all were statistically significant. Now, when they adjusted those outcomes following nearest neighbor matching, the ones that remained statistically significant were only the 24-hour survival and the 30-day survival. So the survival to discharge was not statistically significant. So in regards to the discussion, they mentioned that while the bolus dose epi is not curative, it basically allows for more time for you for recognition, diagnosis, and definitive treatment of whatever condition may be at hand, and identified the patients who received the bolus dose epi after protocol implementation had worse outcomes than similarly eligible patients before protocol implementation. And mentioned that this would suggest that an intervention that adversely impacts patient care. So however, further analysis of the cases demonstrated that in spite of robust adjustments for potential confounders, the subset of post-protocol patients who received bolus dose epi were likely sicker than eligible patients matched before protocol implementation. But I think one of the really important parts that I wish that they made more, like we said earlier, towards the beginning of the paper, but also throughout the paper a little bit more than they did, that these findings highlight the challenge of drawing causal conclusions from a retrospective analysis. And it suggests that the need for a randomized controlled trial of bolus dose epi needs to be performed before we try to try to draw any type of conclusion. And that the ideal bolus dose vasopressor may be patient dependent, as well as exist with respect to indication, agent, and dose. There are lots of limitations in the article that they tried to adjust for. And again, it's really difficult to adjust this type of study. It's difficult to adjust for all of the different variables, but there was lots of potential for recall bias, a lot of potential for selection bias, a lot of potential for survival bias as well. So the conclusion of the article that bolus dose epi, when administered during profound pre-hospital hypotension, there was a noted increase in blood pressure. Bolus dose epi decreases hypotension dose and may create a window of opportunity to initiate other resuscitative measures. And despite robust measures to attempt to control for the confounding, bolus dose epi remain associated with increased mortality in this particular study. And that further study is studies are necessary to determine the optimal indication, dose, and agent for use as a pre-hospital bolus.
Yeah, so you guys want to talk about all this stuff we discussed a few hours ago?
Yes. So Matt, you brought up some good points.
So there's a couple of things here. I mean, you look at table 1. The first thing that jumps out at me is trauma is approximately 30% of the overall patients.
Table 1's always your baseline characteristics.
Yeah. So, 1,000 patients is, 31% of the no push dose, 26% of the push dose cohort are trauma patients. Push dose epi and trauma, I think,
We look at pressures of trauma because you have catecholamine surge, and that's why it works better in sepsis because
Sure.
you get somebody 2-3 days out, they have low catecholamines from sepsis.
Right.
And this has been studied, way long before our time.
And there's
Hypotension, clot formation.
Sure. So that's one issue. Also staying in the same